I've already done that. It was my birthday yesterday, and my
Happy
family they
birthday.
go crazy because there's nothing I can do for them because they never they never stop going crazy, and I appreciate that.
Pastor Lori, I would sing to you, but I can't dare sing to you because you are such a good singer.
This is the good thing about this is a good thing about being having friends that can sing and friends that cannot. Nice, very nice.
We also work with the Hispanic community. So I was doing a meeting with a group of Hispanic. There were a lot, like 65.
Oh,
Yeah.
huge.
So what they do is that they do it at lunchtime. So we're going to have lunch.
That's what I told them. I said, I think we meet for
Yeah.
fellowship and food. I said, we did it on a Friday night.
Yeah. 65 people. So one of the persons there, she sings for one of these mariachi.
Oh,
Then it was my birthday that day.
oh. Wow. And we have the listen, Dr. Calvino's birthday. We'll still sing happy birthday. No one to go. I did. You're right about that. And so we're live here. We want to thank everybody for joining us. We're so excited because this is our opportunity to continue with our health and healing initiative through the Ministers Alliance of Rhode Island. Very, very grateful to the members of the Masjid Jannat. Did I say that right? Not I told us something else. Sumratul Jannat. Remind me of that. To be able to bring this conversation to the community. We're joined by Dr. Calvino, who's our expert, and he's wonderful in talking to us about these things that are important. Joined by Reverend Farley and Pastor Pam Bird here from the Ministers Alliance of Rhode Island. Very, very grateful for Reverend Howard Jenkins, our wonderful leader and commander. Just to remind you, this Health and Healing Initiative is really about cancer screenings. We want to increase the survivalship, and we want to also give support, lend support to cancer survivors and their families. One of the things that we're learning through these community conversations, that cancer just doesn't happen to you. Your whole family is impacted. What we have found out, and we're really emphasizing, is that screenings, checkups, those things save lives. We've been focusing on four, I said four, four screenable cancers, but we're also including prostate cancer. But we've been talking about colorectal cancer, breast cancer, lung cancer, and cervical cancer. And so these are the things that generally in communities of faith, we don't like to talk about those tasty bits because it's a difficult conversation for us to have. But because we have been in partnership not only with the Rhode Island Department of Health and Rhode Island Foundation and United Healthcare and cancer.org. And the Latino Cancer Control Prevention Task Force. We have community health workers. What we've been hearing in these community conversations, Khadija, is that screenings really increase survivorship. One of the things that Dr. Calvino will talk to us about is about these screenings. The people in the Black, Brown, and people of color, Indigenous population, we generally are not going to see our doctors early enough, regularly enough to be able to get the intervention early as possible. And oftentimes we in the faith community believe we all believe in the power of prayer. Amen. I mean, we all believe in the power of prayer, but sometimes we forget that God has also elevated doctors to a position of trust and expertise. And there are some things we just got to go to the doctor for. We got to go. We have to see. We have to treat this temple right. We have to treat our bodies right. And so the Ministers Alliance has come to want. We want to try to increase cancer screening rates and survivorship and support for Rhode Island's Black and Brown community. That is our um, focus. Cervical cancer, that's about getting your pap smear done regularly. Breast cancer, mammograms save a life. So colorectal cancer, although the doctor will talk to us about, although there are, those are home screening um, hits, really colonoscopies are the gold standard. And I know we don't like to get those done, but they can save lives. And lung cancer, we stop smoking, amen. We can reduce those cancer rates. And prostate cancer, because this is, men's, not only Father's Day is coming up, not only is June Men's Mental Health Awareness Month, we really do want to encourage our brothers to talk about getting, their prostate exams regularly. We are finding in our experience that when there's a family history of cancer, it's important that you tell your doctor. So we have been emphasizing the tool that the Department of Health has provided to us, which is a family health screening tool where you can sit down with your family over dinner, over family gatherings, to talk about the history of grandma, grandpa, mom and dad, nephews, nieces, uncles, about not only cancer, but other health concerns, so that when you go to the doctor, you're able to provide them as much comprehensive information about yourself. We also, as we transition out of these community conversations, we'll be transitioning into really cancer screenings. We have Misty Harris, who has joined us as our community health worker. We really will be pushing, people, or encouraging. Pushing is not a good word. Encouraging people to go to your doctor, to get the screenings. Please don't for those of you who are watching, please do not let insurance be a reason that you do not go to your doctor. Please don't we have resources. We can connect you to people and agencies who can make sure that you get the health insurance coverage that you need. Um, early intervention, screenings. You'll hear me say that all through this presentation: screenings. And we're also, after we have some months sharing in cancer screenings, we will be doing some survivor support work, really to talk with cancer survivors, because we really want everyone to know that cancer does not have to be a death sentence. Just because you hear the word cancer, we have Pastor Pam Berg here, who herself is a survivor of breast cancer. It does not have to be a death sentence. Really, screenings, recommended screenings, going to your routine screenings to find cancer earlier when it's more treatable. And we found that some cancers found early enough are even curable. But it doesn't mean that you still don't have to take care of yourself. We understand that some cancers may run in families, and so we need to make sure that that people can inherit certain genes that might make it more likely that they could develop certain cancers. Having relatives who were diagnosed with the same type of cancer might mean that you may need to get screened early. So let's talk about colorectal cancer, colonoscopies. It used to be 50, now it's 45. And if you have direct family members, looking at Dr. Calvin, we're going to turn around this in a second, you may need to get screened earlier. That's why it's important, as you see this link from the Rhode Island Department of Health about the health history tool. We, as people of color, people in the minority community, can no longer be afraid to talk about these things, about health, about diabetes, about hypertension, about cancer. We need to be able to talk about it because we really do want our children and their children to survive. We have said without a shadow of a doubt that knowledge is power. We want to take this time to thank the Department of Health for being such a wonderful partner, United Healthcare, the Rhode Island Public Health Association, Care New England, Stages of Freedom, Planned Parenthood of Southern New England, Charter Care, the American Cancer Society, Veterans Administrative Hospital. You act like I know this off my head. I'm reading it. Rhode Island Cancer Latino Task Force, Community Health Workers Association, and Primary Care Providers. And with that, I'm going to stop sharing my screen and I'm going to turn it over to Dr. Calvino, who will give us some wonderful, wonderful information. You're going to see his lovely face. You can sit right there, sir.
Okay. Hi, Kelly. How are you? I see Kelly there and Misty. So I think if I do a couple more of this, you're not gonna need me anymore.
That's not true. You have 4
I think that one of the important things, hey Kelly, one of the important things to discuss is that um, African Americans or Blacks and Hispanics and minority groups die more from cancer. It's not like they don't, that whites, Caucasians, or groups that have more access don't get cancer. They actually get higher levels of the incidence is higher. But minority groups die more. So the mortality is higher in those groups. And that's why we're having this conversation, because once we realized that, which took some time for us to realize that that was happening, we started to think, okay, so why is that happening? And it's multiple things. One is access to care. So if I want to go to the doctor, if I want to get my screening, can I get it done? Well, that depends if you have insurance or not. If there is in your state any if there's in your state any ability to get screened if you are uninsured. So access to care is very important. And the second thing is have to be culturally and it needs to be sensitive in the language that is used. If you only speak Spanish or if you speak a different language, then it's going to be very difficult to understand and get educated. So then you can do what you need to do to get your cancer diagnosed early. Getting an early diagnosis of cancer is what makes the difference between being alive 5 years, between cure, and between being alive 6 months to 12 months. So that's why cancer screening is important. In Rhode Island, which is very similar to the rest of the U.S., deaths from colorectal cancer, for example, colorectal cancer is the second most deadly cancer. Yeah. You know how many people die from colorectal cancer in the U.S.? Around 53,000 people die every year. Wow. That's the mortality. So sometimes we cannot see the big picture when we look at small groups. There are 153,000 new cases a year. 153,000 in the U.S. new cases, and from those in the U.S. Only colorectal. We're not even talking about breast and the other ones. And from those, around 52,000 will die from that cancer. So it's a huge number. That's right. And then, so that's why we're talking here, because we know if we can start talking in the communities, educating, then we can deal with the other parts. So education is just a part of it. Second part after you get educated is that, well, doc, I'm on board. How do I get my screening done? And that's the second part. And that's why it's so important to have all these partners that you have, so they can help with that. In Rhode Island, we have for example, for women's screening, the Women's Screening Cancer Program, which will allow any woman to have their pap smear or mammogram, even if they don't have insurance, which is not common in a lot of states. But going back to colorectal and other cancers, what we want is we want to make sure that we can make the diagnosis early, because an early stage means we can cure the cancer. If we cannot do that, Then we have some other options. We have chemotherapy, which is using medications that won't kill the cancer cells, but also kill other cells. So that's why you have side effects. So if we don't have to get to that, that would be better. But if we have to, we do that. And then we combine different things, surgery with chemotherapy, and a new type of medication called immunotherapy. Targeted therapies is a little more complicated, but those are used for patients that are more advanced. Yeah. So what we want is to detect it early, so we can treat it and we can hopefully cure it. So we need people to know which cancer can we prevent. There are some cancers we cannot. There's some bad cancers that we cannot prevent, like pancreatic cancer. Yeah, that's why we don't have a screening test for. So we can do screening for the ones, the kind of the most common ones: breast cancer, mammogram, colorectal cancer, colonoscopy, or depending on the case, you can do a stool-based test, which is you get a sample of the stool and then you do the testing. And you can also do PSA, which is a test for blood for prostate cancer, and for cervical cancer, you can do the Pap smear. And since we are, hey, here, I move this. You can sit there. And since we're talking about cancer prevention, we have to talk about, and I know it's kind of a topic that sometimes can be difficult, but about certain vaccines that actually prevent infections that will cause cancer. So, for example, the papillomavirus vaccine can prevent from getting infected with HPV, human papillomavirus, and that will definitely have an impact decreasing cervical cancer. So now the recommendation is any men and women, men too, because initially we thought only women, but no, men to get a vaccine for HPV so they can decrease the chances of cervical cancer. Yeah, because they transmit the virus. So if you do the vaccine to both, then you decrease transmission and also the virus getting into the cervix, producing inflammation, which is what you're going to see when you do the Pap smear. You're looking for inflammation and cells that are changing. But usually they change because there is an infection there, and most commonly is the papillomavirus infection. Yeah. Yeah. So we have to talk obviously about vaccines as well. Going back to colorectal cancer, screening, which is colonoscopy, then young patient started 45, as you mentioned. If there was a family member, then 10 years before the family member got colon cancer. And those are what we call high-risk populations. So if you have a family member who had pancreatic cancer, colon cancer, different type of cancers, you are already a high risk. So those are the persons who have to go and check themselves even earlier than before. In terms of colorectal cancer, again, the best test or the best screening is the one that gets done. So if you have someone who, for some reason, after learning about colonoscopy and how colonoscopy can actually prevent cancer, because cancer starts in the large intestine like a small thing and start growing and then becomes cancer. But if you do a colonoscopy and you can remove that nodule, that small polyp, then it might not become cancer, so you're preventing cancer. You don't do that with the stool test. With the stool test, you're just identifying cancer cells or cancer proteins and blood. So you already have the cancer if the test is positive. With colonoscopy, you're identifying lesions that could become cancer, and therefore you decrease the incidence. That's why the incidence, which is the number of cases, even when it sounds 53,000, 55,000 sounds like a high number, has been coming down. It's in every group age except younger patients has been coming down. In younger patients between 40 and 50, that's the only age group where the incidence of the number of cancer has been going up. And that's why we recommended we should start screening 45 to capture more of those patients. So yeah, that's where we are with colorectal cancer. Breast cancer, very similar situation, and prostate cancer as well. Now it's just a sample. People say you don't have to, prostate. You don't have to do the finger anymore. Yeah, something like this. Yeah. Yeah. Now, if the blood test is high, then you might need an exam, or you might need something called an MRI or ultrasound, and then biopsies and all the things. But that's when the blood test is high. In the past, they used to do that to everybody, but now they used to do blood test. Yeah.
So where do they actually blood test? What days do they start with blood?
So for prostate, it varies. So if you have anyone in the family with prostate cancer, you need to start it early. Some guidelines says 45, some guidelines says 50. So around that age. It's the same thing with breast cancer. Not all the groups recommend starting screening at the same age. Yeah, some more early, 40, some a little bit later, around 40, 45. So it's kind of.
Yes, so how accurate is the blood when you doing the blood test? How accurate it is compared to you going with nothing off and doing the chemo to the system?
Well, the blood is more for prostate cancer.
Yeah.
You cannot do the blood for colon. We don't have a test for colon cancer, which is the one you're going to be split with the camera. Yeah. We don't have a blood for that one. We just have blood for prostate. I don't know if you ever had a prostate test in the past. You go to the doctor, and they will put a finger, try to feel the prostate to see if there's any nodularities in the prostate. That's the part that now we know that the blood is. Yeah. Now, when you have the colonoscopy, which they put the camera and the instrument, there you are sedated. So you don't, you don't feel like, you don't feel like it. And that's usually.
What are the guidelines for when you should do it?
In general, 45.
45.
If you are what we call average risk, meaning no one in your family had colon cancer, you don't have any risk, 45.
Okay, 10 years?
If there's nothing, meaning it's clean, 10 years. Yeah. Because we know there's time. Cancer takes time so the whole process takes time. Let's say you have one, it's clean, but in 5 years you start having symptoms that could be related with it, then you get another one. But in general, if you have no symptoms, you wait 10 years.
And what would be the symptoms related to?
Yeah. So blood in the stool is one of the first things that you might see, depending where the cancer is located. Patients never had constipation, and suddenly they start having constipation. Patients who had it all their life, then it's not. But if suddenly you start having constipation, if you have constipation with abdominal pain, that also might be a sign that you have a cancer that is obstructing the large intestine and things don't go through. And then that's why you get pain and bloated. And then the blood, sometimes you can see it in the stool.
Then you said that colon cancer starts in the large intestine?
Yeah, large. Colon and large intestine is the same thing. So large intestine is just the common word. Colon is the large intestine, yeah. So the same thing. Yeah. Yeah. So the large intestine, which is, come from the right side, comes across, and that's the colon. And then the rectum, that's why it's called colorectal, is because it's the last portion when you store stool to then poop. It's a rectum. It's a little bit different. The texture and the muscles are different than the rest, and that's why it's called rectum instead of colon. So people say colorectal, but it's pretty much the large intestine.
Okay.
Yeah.
Okay.
Yeah.
What about the small intestine?
We don't have we don't have any screening for small bowel cancer. It would happen too. but we don't have any screening because small bowel cancer is not as common. So then there's no benefit in doing screening. You will have to screen too many people, and we don't have a good test for it. So we don't have a camera long enough to get there. Yeah. You can screen for gastric cancer because you can put the camera from the mouth and take a look at the stomach in certain cases, but not all of them.
So if you do,
Here you can use this.
no, I can do it.
Oh, yeah. Oh, what is it?
All right, okay.
We were just talking about cancer. Yeah. So, we were just talking about
This
cancer.
is my natural last name.
Uh-huh.
So. So my daughter told me next 10
You
years.
don't look 45.
Well, more than 40.
And it was good. I mean, yeah. So you're good. Yeah.
Yeah.
So if you didn't have anything, then it's 10 years.
Yeah.
If they find something though, if there is a small polyp, a small growth, then sometimes they can recommend it 3 years, depending on the pathology. What exactly is it? 5 years. Sometimes you need to have it 6 months or a year after. Yeah. So we have patients sometimes you take out a polyp and there's a little bit of cancer in the polyp, and then but you remove it already. So then that patient you might come back in 6 months just to make sure it's clean, because then you don't need to do a surgery. If the cancer is in the polyp and already going into the large intestine, then you need surgery, where we will remove that part of the large intestine and put things back together.
Yes, so that it takes that long for you to detect it, like the way they go for number every year, right? So they will go this year and next year, so they pass off.
Yeah.
It is very important for, like, it's called give you 10 years.
Yeah.
I think we do that.
Yeah, that's a good question. So the breast is a different organ, so it works different. And in the colon, it takes that long time to have cancer, but in the breast could be faster, which doesn't mean, and this might get a little bit more complicated, doesn't mean it's more, doesn't mean you're gonna die more from breast cancer than colon cancer. Colon cancer is actually more deadly, but it takes longer. Breast cancer could happen in a year or two. So, yeah, that's why. But it's just a different, in every organ, the way the cancer behaves in every organ is different. That's why we use the word cancer, but there are many types. They behave different.
Yeah.
Cancer in the pancreas will kill you more than cancer in the colon, and that one will kill you more than cancer in the breast. But cancer in the breast is more common. So yeah, very interesting topic.
You had a question? No. So one of the things that you said that people of color, Black people, die more.
Yes.
Is there a reason?
So it doesn't have to be. So one, there is some studies that show that even when all we look the same genetically, meaning my genes, our genes are 95% the same. The cancer that you might get might be different than the one I get. Okay? So one part of it is that sometimes the cancer you get or certain groups of the population get might be more aggressive. That's one small group, small part. But in general, it's because specific ethnic groups have been have less access to healthcare, have less education, have less opportunity to get to a doctor, You know, so we know that those groups are not going to have access to screening. And then when they present with cancer, they present with more advanced cancer. And then the mortality is higher.
So, doctor, can you tell us about like people, they say stage 1, stage, what does that mean?
There are 4 stages.
Yeah.
And so stage 1 means that the cancer is just starting in whatever organ it is. Could be breast, stage 1 breast cancer, stage 1 colon cancer. Stage 2 means it's a little bit bigger, but still in the organ.
The cancer piece.
Yeah.
Okay.
So instead of being something small, not too deep, now you have something deeper in the organ, in the roots of the organ.
That's how cancer travels.
Yeah, that's exactly how it travels. But still in the organ. Stage 3 means that it's not only in the organ, but has attacked the lymphatic system. What is that? The lymphatic system is like a defense system that we have in our body. For example, when you cut yourself and you cut with you're cooking something, that knife is dirty. But you're not going to necessarily have an infection there, right? But there were bacteria in the knife, and you cut yourself. So how come I don't get an infection, right? Because we have the lymphatic system that is like a defense system, and it will send cells there to fight any bacteria. And then we heal. So the same thing happened with the cancer. The body can actually recognize when one of the cells is not normal. It's a cancer cell. And sometimes the body can attack that cell and repair itself. Yes. However, if the cell is growing too much, the body sometimes cannot recognize it and start growing, right? So interestingly, when the cancer starts growing, the first place it's going to go is to the lymph nodes or the lymphatic system, which is the system that produces the cells that are going to go and attack the cancer. So it's like in a war, and you go to the military bases, kind of like that, right?
Yeah.
You're not going to be attacking the soldiers. Well, where are the soldiers at? In the military base. Oh, well, let's attack the military base. So we don't have more soldiers coming.
Yeah.
Kind of like that. That's an analogy there. But yeah. So that's stage 3.
Yeah.
And then after they go to the lymph node, sometimes they can go to other organs, the liver, the lungs, the brain. They can go anywhere. That's a stage 4. And that's the highest stage. Yeah. Once you get to stage 4, there's things we can do to treat it, but the chances of curing the cancer is way lower. Yeah. So if stage 1 and stage 2, those are very curable for colorectal and for most of the cancers. Then stage 3, when you have stage 3, you need to get chemotherapy. Because now we know the cancer cells somewhere else. So we have to kill them. We need to kill them everywhere. So we have to use chemotherapy. And stage 4, obviously, chemotherapy plus some other things.
Actually, we go for that.
That's right. That's right. There are some cancers where we have gotten better at treating those cancers, and we can cure cancers that are stage 4. So it's not completely game over. Actually, colorectal cancer, sometimes, and we've had many patients that have cancer in the colon or the large intestine and in the liver. And we can give them chemotherapy, take out the colon or part of the colon, and take out part of the liver. And some of those patients, not too many, between 20 and 40% of those patients might be cured, meaning after 5 years, they have no evidence of disease. That could still happen. But you'd rather try to get it early.
And so if you take out a part of the colon, do you have to get a colonoscopy back or?
Colostomy back? It depends on where's the colon. So most of the time you get a, now I'm saying colonoscopy back if the cancer is in the lower rectum. Why? Because it's like having a pipe If you have a problem with the mid portion of the pipe, you can cut that and you can put something in between the two pipes. But if you have a problem at the end of the pipe, now you have the problem that if you cut here, you have nothing to connect to. So if it's two-way in the last portion of the pipe, so the anus is here, you know, that muscle that you tight when you don't want to go too far. But if the cancer is there, and that muscle is not going to work because we have to remove the muscle, or we have to remove it too close to that muscle, then we have nothing else to connect it to. So that's when you might end up with a colostomy.
So I think like a lot of people, when they hear colon cancer, they say, well, if I have it, I have to have a bag. And rather than,
Do you know that it's more common to have a colostomy bag, temporary colostomy bag, from non-cancer problems in the colon? So something called diverticulitis, many people have them. It's more likely you might end up having one because of that than colon cancer. Yeah, because the diverticulitis, you have a perforation of that small pouch in the large intestine, you have an infection, and then we cannot put things back together with this infection. The back,
Yeah, like about 15 years ago.
yeah.
I learned one birthday. So,
And then they put you back together.
Yeah, they
Yeah.
cut the piece from the back, then they do the same. Because
Yeah.
the check must make sure there is no cancer.
That's right.
If it is cancer, then you have to carry the bag.
No, I mean, better if it's not cancer.
Yeah.
But even if it is cancer, we can put you back together. Yeah, because usually the location is here, so we still have more pipe now. So we can.
So there is like.
That's right.
What is the common cancer in that?
The most prostate cancer is the number one, the most common cancer, prostate. Then colon cancer and lung cancer if they smoke. Yeah,
Even second is more, they can have.
you could have lung cancer even if you don't smoke.
Yeah.
But the risk of having lung cancer increases exponentially if you smoke. Yeah. And for females is the breast cancer, cervical cancer, and then colon cancer.
Now, what about bladder? Some people have bladder cancer.
Bladder cancer. Okay, yes. So bladder cancer is way lower, so it's less common, but it could happen too. Yeah, you can have bladder cancer. You can have liver cancer.
Yeah.
You can have gastric cancer, so in the stomach.
But
But the most common liver is, so liver is usually, you could have it because of an infection, hepatitis, or you can have it sometimes if you have something called cirrhosis, which is like a scarring of the liver. And that can happen in patients who drink too much alcohol. Yep. So you have cirrhosis and then you develop cancer. Anything that damages the cell can cause cancer. Alcohol, smoking, different type of drugs, viruses, infections, anything that
damages the cell can cause cancer.
Once some people they have a cancer tumor. They
Yep.
After remove the tumor,
Yep.
after 6 years, 5 years, 10 years, it comes back.
comes back. That's right.
Regrowth. It never.
Yeah. Unfortunately, that could happen. It's called recurrence. So once you have predisposition to a cancer, you could have it again, even if we remove it. That could happen, can reoccur. Yeah, that's why it's important survivorship.
Yes.
So that's the part that focuses on, okay, you got cancer, you got surgery, and you're good now. But how do we keep you like that for the next 30 years? That's where survivorship is important. We need to know exactly if you have a problem in the future. We need to know what cancer you had, what treatment you got, when was it diagnosed. You're gonna need a colonoscopy more often. You're gonna need CT scan. You're gonna need some other things. That's the whole survivorship part of it. How to actually survive.
How to survive.
Almost is very.
The next phase is survivorship. So once they have a surgery or whatever is needed or the treatment, we have to learn how to stay cancer-free.
Yeah, that's right.
Through treatment or through seeing your doctor all the time or.
So survivorship. So yes, it's a little bit of all of those. The problem we have right now is that not every doctor has been trained to do survivorship. So not every primary care physician, they might have an idea, but they won't be able to put together a paper that said you have this cancer, you have this treatment, you have this, and this is what you need to do to make sure it doesn't come back.
Specialist.
You need a specialist. And because you need a specialist, because well, they know all the things. They can treat your diabetes, your hypertension. Yeah.
And it looks okay. But when they go through special tests, they're diagnosed with hepatitis because the regular blood test was clear.
Was clear. Yeah. Sometimes that can happen. And the problem is that not all the specialists have a program. When I say a program is, you need to be sure that if you have cancer, you're being seen in a cancer center, then you will have access to having a plan. But not all the cancer centers have that, and not all the clinics have that. So that's why we are
Yeah.
every cancer center needs to have what is called an accreditation, which means someone go and check, okay, as a cancer center, do you have plans for your patients who have cancer? Yeah. So most of the cases, yes. The specialist will do it, and he will send a copy to the family doctor.
Yeah.
But the family doctor is not trained to do that. The same way I cannot treat diabetes. You know, you don't want to see me for diabetes.
I'm thinking, okay, the PCP refers to you.
That's right.
If you would come up with a plan for that patient to follow.
Correct.
Okay, now, once they are referred to you, they're always yours.
That's right.
Okay,
That is
that's
right.
what we need to know, because some people, you're referred one time, and then that's it.
Yeah, no. It's as you said, once the patient has cancer, it's referred to medical oncology or any type of oncologist that is taking care of the patient. That patient becomes part of that patient care.
Yeah.
So do you have any questions for the doctor? He's here giving us a lot of knowledge, a lot of information. I mean, I'm always blowing my mind.
So let me ask you a question now that I have all these leaders in the community. So have you had, I was going to say patients, but not patients. Have you had people who want to get their test done or that is interested, but don't have insurance?
Yes.
So
So now what we have is, we just hired, a community health worker. So what Steve will be doing is we find out, this is what we have, we fill out the form and we ask if you have insurance, because if you don't have insurance, we will navigate you to get insurance through Health Social.
That's right.
Healthcare, because you can get insurance, you can. And if you have a problem getting insurance, that we will have someone know how to get you to get insurance, because it should be pretty much, should have insurance.
Yeah. So that's the first step. The first step is having access, which is insurance.
Yes, yes.
The second problem we see, and there's no one from the Hispanic group here, but is illegal immigrants.
Undocumented.
Because
yes.
those are the ones who cannot get insurance.
Right. But
That becomes a
right, and so we're
Extreme.
finding out that there are some free screenings for the women, mammograms
yes.
screening
For women, because of the Rhode Island Women Screening Program run by the Department of Health through a CDC grant, which is incredible, that anyone, even uninsured, can get
right.
their test. The problem with colorectal becomes a little more difficult.
And housing, which is screening, because if you're doing all this for the women,
Yeah,
they
sure.
should be covered as well.
Yeah,
It's free screening, even though it's
Right.
just a blood test, but still.
they figure it out early who's important, you know.
Now the doctor's being controversial.
And that'll be okay. Women, yeah, we need a program.
And see the cancer also, seeing if we can get into more about prevention of smoking.
Yeah.
You know,
Smoking cessation.
yes,
Smoking cessation.
smoking cessation, yes, so that we can help them. Because that's not free either, that screening is not free.
That's right. Yeah. It's
Yeah, so,
and then the next problem is when you get cancer diagnosis. Like if you get a cancer diagnosis, then the treatment. So there's a lot of things that still needs to be worked out. But one thing we know is that there's a lot of people who have access to care, meaning they have insurance, and they just don't do the test because they didn't know or they didn't think it was important. So that's why education is so important. That's why the Department of Health is working with us, try to reach, try to get people who learn about it.
yeah,
We have almost experts. They can talk to people.
that's what we're trying to do, that is our goal, is to educate.
Screening. Brother, screening.
One of my friend, he just died with cancer. He's a 53-year-old, very healthy, but he don't going to doctor, never no go for checkup.
That is a big
So
one.
then he feel the pain and he's a fisherman. So he go to doctor within 2 months.
People say that, you don't do much treatment, but he had cancer.
Right.
When he was back, when he
That's right.
got it straightened out.
It's always good even to get your.
What about the illegal ones? Check if someone, man, is illegal. And they want to have a screening for prostate. No. Insurance are not.
If that's the case, I think some federal FQAC, federal qualified health centers, so like Providence Health Centers, you could still go there because they get some federal funding for primary care of underserved uninsured population. So if you have someone who doesn't have insurance, they can still go to the federal qualified health centers. So they receive federal funding to help. So they are supposed to help.
That's good.
Yes.
And there's no need from the immigrants, people come to visit.
Yeah.
Africa come to visit. And in that time,
Yes.
nothing with.
Yeah.
And they don't have insurance.
So yeah. So that changed things a little bit. If you're having symptoms and it's painful to go, but you can go to an ER. And in the ER, they will do the test. They have to. Yeah. So, you know, I did my training. This is moving away from it, but I did my training in Chicago. And my wife was training at Cook County Hospital.
That's where I was born.
Oh, really?
Yes.
Chicago. They have a new one. You were born probably in the old?
Was born last decade. Old hospital.
Old Cook County Hospital. Now it's called John H. Stroke Cook County Hospital.
They need to do all of that. Yes.
So in that hospital, when we had rotations, we had patients who will come from the airport with their suitcase directly to the ER.
Yeah, because they figure, yeah.
I have that happen. And because the True County Hospital it is a hospital for underserved, for Medicaid patients, they will take care of. I mean, they get funding for that, but
That's a lot to get health coverage. Um,
the other option you have, this is between us, is you can move to Massachusetts. So Massachusetts has, C. Kelly turned the Massachusetts has mass health,
Yeah.
universal,
Yeah.
which we don't have here in Rhode Island. It's with they go here, yes.
Yeah.
Yeah, you can get mass health, which is universal, so anyone can get insurance.
They ask for income tax.
Was that? Oh, you have to justify it, yeah.
They have to.
But even if you don't work,
Yeah.
like for example, I was talking with a friend who works at BMC. BMC is Boston Medical Center. Yeah, you don't work, you go there, you get care. Yeah. So it's better than in most of the other states.
Yeah.
You know, I'm not saying that this is the best way,
But you just say this option.
but I would think just making sure everybody has access to health services should be a basic thing.
Because as we said earlier, screenings, that's why we are encouraging 45, start getting your colonoscopy, breast, mammograms, women going to see a doctor regularly, men, screenings early, because if you catch it early, it may be painful, but it's more expensive, the more aggressive the cancer is.
And that's one of the things we have been trying to demonstrate is that screening is cheaper than taking care of advanced cancer. That's way more expensive.
More comfortable.
Size that, but cancer care is very expensive. So better not to, and you can help a lot of people at the same time instead of this population-based strategy instead of just one person at a time. I can operate in one person, but how many persons can I operate on in my entire career?
Right.
When you can probably get a full group of population to prevent cancer.
Yeah. So do you usually have to ask your doctor, let's say for the colorectal, like one of that takes the blood test, right?
No,
Colorectal is colonoscopy. Large intestine is colonoscopy.
Oh, okay. Oh,
Well,
prostate.
you also-
Prostate one is the
Yeah,
blood.
you could also do the stool test. But
Yeah.
yeah.
But you usually have to advocate for yourself, or your doctors know when you go for a certain, at a certain age.
Ideally,
Ask you.
they should.
Yeah. It's time to do-
Ideally, they should tell you, but the reality is that sometimes they're busy, they have a lot of patients. You might have a problem with diabetes, with hypertension, with cholesterol. Maybe they forget about the screening test because they're more worried about your diabetes, and it might also kill you from different aspects or other things. So it would be good to assess, hey, doctor, I'm 50. I haven't done anything. What do I need to do?
Yeah.
And then yeah. Yeah, that's the way it should be.
Yeah.
3 days.
More tests now.
Mostly, they're so busy, they don't get honest.
Yeah, that's right.
So look at, if you're healthy, You don't need all of these, but you have.
Now I know, when you are happy,
I would say you can test anyway.
So yeah,
I think you have to,
that's right.
but especially with my heart, you still want an EKG every year. Just in case, you know.
Yeah, so the main two things, so once you like, let's say this group here, right? Very smart group of people, and probably you're thinking, okay, I want to do whatever I need to do to live as long as I can healthy, right? So I'll say, well, that's great. The main two things that are going to kill you, if it's not an accident in the highway or something like that, are a heart attack or cardiovascular disease and cancer, right? So knowing that those are the main two, when I go to my doctor, I just said, look, what do I need to do to make sure my heart and arteries are good and to make sure I don't get cancer, or if I get it, we can pick it up early. And that's why it's cardiovascular screening and cancer screening.
But if arteries block,
Mhm.
what is the best way to control this?
So the best way is to prevent the arteries from getting blocked, so they can start you on medications early on. So the fat doesn't get into the arteries with the blood, and you have a heart attack, or also strokes. Yes, both of them are most of the time because of the arteries. You have problems. So exercising, diet, exercise, diet, medication. Once you have the artery blocked, then we can only, or what cardiologists and some other doctors will do, is they can try to open up the artery with a stent, or sometimes they can do a surgery, do something called a bypass. It's more, but a lot of people will get a stent.
But the medicines
Help, yes, they do help. Yep.
Her 300 river blocks. So all of a sudden, she was feeling great. Then we said that some occasionally people look, healthy, but they are not healthy.
That's right.
Because they were never checked. So she was complaining about shoulder pain, and she was looking at the way to go. I told her family that. We check her, like, no test, symptom.
Yeah.
So he told me, come and say, hey, I already come out of the hospital.
Oh,
She need to go to the hospital. She was not really good to go to the hospital.
red shoulder pain. Because that is really pain.
So,
But that's not maybe that is because of
that's the reason why we don't see the doctor.
that's right.
We are scared, don't want to hear something bad.
That's right.
We already are happy. I don't want to see doctor to hear bad news.
That's right.
But then we come say, oh, he was healthy. Like if somebody have hepatitis C, so he looks really healthy, looking, then he becomes sick. Then we say, oh, then we see Dr. Benedict too.
And it's interesting that you bring these things up, because one of the things the Alliance has been talking to people about is know how you regularly feel, so that you can go to your doctor when you're not feeling the way that you regularly feel. As Dr. Calvino said, that when our body functions are no longer normal, like we're no longer going to the bathroom as regularly as we should call our doctor. We're not inconveniencing them. We should tell them something's not right. And I hope we've been saying that if your doctor doesn't answer you the way that you feel, find another doctor, call somebody else, because it's important. Also important to tell your family about your history. And we have a question in the chat. Is genetic testing something that can help in cancer prevention?
Yes. So once you have, depending what type of cancer,
Yes.
but for example, breast cancer, we do it for colorectal cancer, we do it for pancreatic cancer. We can do a test to see if you have a specific mutation. And then if you have that mutation, there are some mutations that can be passed through the different generations, so are hereditary. So if you have one of those mutations, then your family needs to be screened earlier and screened for that mutation. For example, breast cancer, you have a mutation in a gene called BRCA1 or 2, BRCA. So if you have that, your family can have that mutation. So it's good to know, because then you can do, and there's another topic, but you can do prophylactic surgery. Meaning, if I know I have that mutation, which means I have 60–80% chances of developing breast cancer, you can have a surgery to remove the breast tissue, the reconstruction. So we decrease by 90% the chances of you getting breast cancer. There are some patients who have a risk of colon cancer by age of 50. That have specific mutations, and we can remove the colon, which is not fun, but you remove the entire colon because you know they're going to get it. So, yeah, so there are some mutations. Yeah, so what we do is that we connect the small intestine to the rectum, depending what type of mutation you have, and then, yeah, you can leave. You're going to have more diarrhea than usual, but
Wow.
About what is the best thing to do, like, I mean, we have to do the screenings, but what's the best thing to do to prevent cancer, like in general?
I would say exercise. Exercise has been proven to help to decrease obesity. Obesity is a risk factor for cancer.
Obesity is a risk factor for cancer.
So what happens is that when you store too much fat, that affects your immune system.
What did you just say?
When you accumulate too much fat, that affects your immune system. So you are not capable of fighting cancer the same way other people will do. That's what we think based on. So that's why, yeah. The other thing that, there's a lot of studies about it, is doing fasting. It seems like fasting is very good. It seems like when you fast, the body, because it doesn't have the sources of sugar and energy that it needs, it might start to reduce things in the body that you don't need. And one of the first things to die are those cells that are not strong enough, that are becoming cancer. So intermittent fasting or fasting, actually Muslims, they fast, before a specific time, right? It's Ramadan. So fasting is associated with a lot of good things for the body. And I'm sure if you go back and study how that started, there must have been some sort of benefit of doing. But fasting has been associated with decreasing the risk of cancer, obesity. Exercising is good. Diet, not eating processed foods helps. Anything that have chemicals will change the cells. So, yep. So those are the things that you can kind of do. And now there's so many options to lose weight, right? There's so many this, that. Take away your hunger. That's right. So some people I have a lot of patients who are on medications to lose weight, they lose a lot of weight. But the most important thing is to change what they eat and how they eat. Because once you stop the medication, go back to eating.
One of my friends is taking the injection. I don't know but I don't know how much about it. But I mean, he's doing very good. Right?
Yeah. So
Yeah.
Yeah, there is not using that, right, but that is not for losing weight. Basically, that is
Diabetes.
for diabetes.
Yeah.
And you are saying the real weight, and then,
But you can,
yeah,
yeah, you can use it for diabetes with all the medications.
right,
But you can also use now. The injection doesn't make you lose weight. What it does is it takes away your hunger. So if you're not hungry, you eat less calories,
you don't have.
and so you don't have to eat. So what's going to happen? Your body's going to use your fat and muscle
That is the same thing if you are in a.
on a diet. Fasting, yeah. The thing is more difficult. If you're not taking the medication, you go home and someone bought something there and the Oreo cookies or the other.
You look on the village personas to get that, it's very expensive,
It is very expensive.
very expensive.
Yeah. So that's why right now, most of the patients who have diabetes, they get approved for those medications.
Mm.
But they are very expensive.
Very expensive.
They are so expensive that something that in the US was not very common is when you have a pharmaceutical that has a medication, you cannot get it if it's not through that pharmaceutical. But it's so expensive and so many people want to have access to it
Yeah.
that you can get it through compound pharmacies.
Mm.
So what that is a pharmacy that creates a similar medication cheaper.
Generic.
So you can do that in the US. Yeah. So you see a lot of those, I think it's called LifeMed or it's compound pharmacies. They send it to you, send it to your house. Instead of paying $1,000 a month,
Yeah.
you pay $100. Yeah. But it's not the medication of the specific commercial name of that pharmacy. It's a compound pharmacy. So
Yeah.
someone put a pharmacy and then mix it and do it and send it to you.
Yeah.
Yeah. That's an option.
Because they know the ingredient. They make their own. Yeah.
Make their own.
Trying to change that, so it's almost 6 months now. He loses almost 50-something pounds.
Good for him. Look, I tell my patients, well, I know a little bit about the medication, obviously, because my patients take it, so I need to learn about it. There's not too many side effects. If you have certain diseases or problems with your thyroid cancer, specific type of thyroid cancer, thyroid is a gland here, then you cannot take some other. But if that's something that can help you lose weight, which is good for you to feel better, for your cardiovascular system, for decreased cancer, to many other things, then do it. Why not? Do whatever. Yeah.
Now, what about water? I know.
There's good.
That
If you don't have any cardiac,
water to flush the system out. Will that reduce chances of cancer? Okay.
yeah. I don't think there's any evidence that drinking more water will reduce your chances of getting cancer.
Mhm.
But there are some other benefits from drinking water.
Yeah, you lose weight.
You get your kidneys work better.
Yeah.
Right?
You lose it really quick.
Yeah, you go to bathroom a lot.
A lot. Your kidneys work better, your system works better. If you're exercising, if you are hydrated, you work harder, you work better, the blood flows better. So there are so many benefits. But I don't think there's a specific relationship with decreasing cancer.
Well, we certainly want to thank Dr. Calvino. Thank you all for participating and asking wonderful questions. We really do want to encourage screens. Get checked, colonoscopy, mammograms, your pap smears, you want a PSA test, is that what it's called? Right, for your prostate, if you're smoking, let's please stop smoking. Please, 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 make sure that you encourage your family and friends to get screening. Know your cancer history. I found out just recently that in my biological family, several people had colon cancer, so I will make sure I will tell my doctor. Yeah, it's important. Yeah, it's important. I just had my colonoscopy too. Yes. So it's very, very important. Screening stable, right? So again, if you have any further questions, if you need any information, any connections, please, Khadija, you know how to get in contact with us. And so we'll be happy to make sure that you get all the information that you need because knowledge is power.
Contact numbers.
Yeah.
Please.
This is Dr. Calvino, he's the- So we want to thank you all for joining. We certainly thank the members of Zoomer for joining us.
I think you probably have done.
Dr. Camino, we are waiting for me on the 29th.
On the 29th of what? Of July? Of June?
Yeah.
Let me double check that.
He's super. So just give it.
You know, you have a bigger gathering than the one you had in our.
Also, that's a Saturday. Saturday 29. Let me see.
So we have a whole, since we finished up this series, let's tell you his story. Yes.
Yes.
Thank you all for joining us.
You can send me, you have my email?
I do. Yeah.
So you can send me an email so I can put it in my calendar.
Yes.
Yeah, I'm here. in town.
Oh, he said that.
Yeah.
So thank you. I hope everybody was able to hear my questions. Appreciate it. Fantastic. Dr. guys.
Cancer Center?
God bless you. Good evening. See
Thank
you.
you very much.
Yeah. Okay.